Ladies and gentlemen, our next topic this afternoon is the current medical treatment for kidney cancer. It gives me great pleasure to introduce Dr. Joel Gingerich, who will speak on this topic. Dr. Gingerich is a medical oncologist with CancerCare, Manitoba in Winnipeg.
Before I start, I would also like to say that dealing and treating patients that have cancer is really a privilege. The courage and fortitude that many of the patients that I've come in contact with have and their families have is really inspirational to me, and it's changed my life in many ways. So I'd like to thank them and thank you. So I'm going to talk about current medical treatment for kidney cancer. And in 20 minutes, you can't talk about everything. So I'm going to try and hit the highlights of where things are at in 2012. And I'm going to do that by talking about four clinical scenarios that are things that we see or talk about on a regular basis in our clinics. So the first clinical scenario is a 55-year-old male who presents after undergoing successful surgery to remove a 6-centimeter right kidney cancer. And he's worried that his cancer could come back in the future. And so the question that comes up, is there any role for systemic therapy now that his cancer has been removed to decrease the chance of it coming back in the future? And this leads to the question of adjuvant therapy. And what adjuvant therapy is giving treatment to reduce the chance of a cancer coming back after all visible cancer has been removed. We know that this has benefit in colon cancer and breast cancer and lung cancer. And so the question is there any role for this in kidney cancer? And a meta-analysis that was published this last year, and a meta-analysis simply looks at all the published data on a specific topic and puts all the data together to come up with an answer, suggested that unfortunately at this point there isn't any benefit for giving adjuvant therapy after all visible cancer has been removed. And so the 2011 Kidney Cancer Forum Consensus Update, which was published earlier this year, says that there's no role for this outside of a clinical trial. But there are studies that are ongoing that are looking at this using some of our newer treatments, and that may change that in the coming years. So the second question or scenario that comes up is, this is a 66-year-old female who's diagnosed or had a history of kidney cancer that was resected, and her kidney cancer showed that it was a clear cell subtype kidney cancer, and this was 3 years ago. A CT scan now unfortunately shows that she has recurrent cancer in her lungs and in her abdominal lymph nodes. She has 2 risk factors, and I'll go through and talk about what those risk factors are. And so the question is, what would be the best treatment for this individual? And I think in order to answer that question, we need to go a little bit, dig into some of the background. And the first part of this is that there are different types of subtypes of kidney cancer. The most common subtype of kidney cancer is clear cell kidney cancer, and about 75% of patients that have kidney cancer will have the clear cell subtype. The second most common type is papillary. It represents, give or take, about 12% of all kidney cancers, and then you have a couple of others that are much less common. This information is important because some of the studies that we're going to talk about that have been done focus in on one subtype more than another, or sometimes they focus in on multiple subtypes, and I'll talk about that and highlight that. The second part of this is that there are some known risk factors for patients that have advanced kidney cancer that suggest that their cancer might be more aggressive. And if you look through the literature, you can come up with a variety of different types. I'm going to just list these 5 because these are 5 well-known and commonly used risk factors for patients that have advanced kidney cancer. And these 5 risk factors include things like having moderate or severe cancer-related symptoms, requiring treatment within a year of being diagnosed of the cancer, having an elevated calcium level within the blood, having a decreased hemoglobin level within the blood, and having an elevated lactate dehydrogenase. It's a blood test that can be done, sometimes called an LDH test. And you can use these 5 variables to put patients into 3 categories. Patients that don't have any of these risk factors would be grouped into what we call the favorable risk group. Those that have 1 or 2 risk factors would be considered in the intermediate risk group, and those that have 3 or more of these risk factors would be considered in the poorer risk group. And all that means is that patients that have less of these risk factors might do better than some that have some of these risk factors or lots of these risk factors. And again, this is important when we think about what treatments might be best to use for an individual, and I'll highlight that as well. Now, in the last few years, as has been mentioned, kidney cancer treatment has come a long way. And it's really based on our understanding of how a kidney cell works and how a kidney cancer cell works. I'm just going to highlight it. So in a normal kidney cell, you have a protein called hypoxia-inducing factor alpha. And when it's present within the kidney cell, it diffuses to the DNA where it causes transcription and production of proteins. One of these proteins is called vascular endothelial growth factor, or VEGF. Essentially what this does is it moves around the blood vessels around the kidney cell, and it causes those kidney cells to grow, which increases nutrient and oxygen delivery to the cell and allows the cell to grow. In a normal kidney cell, this is highly regulated, so that in a normal oxygen environment, there's a protein called von Hippel-Lindau protein. And when this is present, it takes hypoxia-inducing factor alpha and breaks it down. And when it gets broken down, it means that those proteins are not produced, and you have a decreased amount of blood vessel formation or growth around the kidney cell, and it means that the oxygen and nutrients aren't delivered or increased to the cell. In a low oxygen environment, the von Hippel-Lindau protein gets broken down. And so what happens is you get a buildup of this hypoxia-inducing factor alpha. And when this is present in higher levels, it means that there's going to be more production of proteins like vascular endothelial growth factor that then diffuse to the blood vessels and allow for increased nutrient delivery and oxygen delivery to the cell and allow that cell to grow. Now, it was determined that about 60 to 80% of kidney cancers have a defect in this von Hippel-Lindau protein. And so what happens is that you get a buildup of this hypoxia-inducing factor alpha even when there's normal oxygen delivery to the cell. And so the net result of this is that you get increased proteins that stimulate blood vessel growth, and you get increased nutrient and oxygen delivery to these kidney cancers, allowing them to grow. So it made sense to try and target this pathway. And a number of the newer treatments specifically target these blood vessel activating proteins to inhibit them, thereby decreasing the amount of oxygen and nutrients that the kidney cancer has and makes the kidney cancers die. And this leads to one of the important papers that was published in 2007 and updated in 2009. This was a randomized controlled trial. That's the best kind of study that we can do to prove that one drug is better than another. And it looked at Sunitinib, which is a drug that targets this blood vessel pathway. And it compared it to our old treatment called interferon. This study had 750 patients on it. All of these patients had clear cell subtype kidney cancer. Almost all of them had good or intermediate risk disease based on those 5 risk factors that we talked about. They had to have controlled blood pressure and have no significant heart problems within the recent past. I'm going to show some results, and I have to just say before I tell or show these results or talk about these results, is that these are just numbers and statistics. And when I'm seeing a patient in front of me, they're not a number or a statistic. You have to take it all with a grain of salt. These are just the middle numbers. Half the patients are going to do better than these numbers, and there's going to be a subgroup of those patients that are going to do much better. There's going to be some patients, unfortunately, who won't do as well. But what this study showed was that those patients that got Sunitinib did significantly better than those patients that got the older treatment called interferon. About 50% of the patients had a significant tumor shrinkage when they got this treatment. Most patients had some tumor shrinkage or at least tumor stabilization. There was about 3% of patients where the disease would completely disappear. Those patients that got Sunitinib had their cancer stabilized for much longer than those that didn't get it. On average, it was around 11 months compared to those that got the old treatment where it was about 5 months. Again, these are just numbers. They also found that patients that got Sunitinib lived longer as well than those that got interferon by an absolute just over 5 months. Now this probably was somewhat, this difference here may have been, it's probably larger than what it's showing up on this graph because most patients that got the old treatment, the interferon, after their tumors show that it was growing, were able to switch over and get something like Sunitinib so that it made the difference between this less than it probably actually is. So Sunitinib made a significant difference in these patients. Sunitinib does have some side effects. Sometimes you can get low blood counts. You can get some kidney damage, as was mentioned earlier this morning, although usually it's mild. Some patients can have diarrhea, tiredness. Some patients will get high blood pressure, about 24% of them. Sometimes they'll require blood pressure medications for that. They can have some nausea and vomiting. Some can get rash. A subset will get thyroid dysfunction, which may need some thyroid replacement. You can have nosebleeds in a small percentage of patients, and sometimes you can get some damage to how well the heart squeezes, although usually it's mild and only picked up on tests. By and large, most patients tolerate this treatment fairly well. There are a number of other blood vessel targeting treatments that have also been looked at in randomized controlled trials and have proven benefit, and I've listed them on this table or this slide. One of them is called bevacizumab, and it was studied in combination with interferon, and it showed a significant improvement. One of the difficulties with this regimen is that patients have to get interferon, and interferon does have some side effects with it. And the other is that bevacizumab is actually not approved for this indication in Canada. That's because the company didn't put in the proper paperwork to get it approved. Pazopanib is another drug that has proven benefit in this situation. It has a different side effect profile than Sunitinib. And so earlier this year, the Pan-Canadian Oncology Drug Review panel came out recommending that pazopanib could be considered for patients who are unable to tolerate Sunitinib or an effective dose of Sunitinib due to side effects. And so this is another option for those individuals. Sorafenib is a third drug that has proven benefit. It has proven benefit in patients that have previously been treated with interferon. Again, our older treatment. Most patients in 2012 don't get treated with interferon. So our patient in this scenario went on to receive Sunitinib and did quite well with it, or did very well with it, for an extended period of time. The third clinical scenario is this one. This is a 78-year-old male, presents with recently diagnosed papillary kidney cancer, the second most common subtype of kidney cancer. He has lymph node, liver, and lung metastases based on CT imaging. And based on those 5 risk factors that we talked about, he has 3 of those 5 risk factors. And so the question is, what might be a good treatment for him? And it turns out that there are other pathways that are important in kidney cancer, and this is one of them. You can have a protein that binds to a receptor on the surface of the kidney cancer cell and can activate it, which then activates other proteins in an intracellular cascade, which eventually then leads to DNA changes that produces proteins that can lead to cell growth and survival, and can also lead to production of hypoxia-inducing factor alpha, which, as we talked about earlier, can also lead to cell growth and survival. If you have a mutation in any one of these proteins or these pathways, the protein that binds to the receptor, any of these proteins, it can turn on this switch. And the switch gets turned on, and this can lead to growth, which can happen in kidney cancer. And so targeting this pathway makes sense. And there's a protein a drug that's been developed that targets this mTOR protein, one of the proteins within this intracellular cascade. And by inhibiting it or turning that off, you can remove the stimulus for growth in kidney cancers. And that leads to another randomized controlled trial that I would like to talk about. This is comparing temsirolimus, which is an mTOR protein inhibitor, comparing it to our old treatment called interferon. This study had just over 600 patients on it. Most of these patients, 74% of them, had poor risk kidney cancer. And non-clear cell histology was allowed in this study, so patients with papillary kidney cancer, and they represented about 20% of the group. Again, these are just numbers, but what they found was that the group that got temsirolimus did significantly better than the group that got interferon, our old treatment. So that just under 10% of them had a significant tumor shrinkage, although much more of them had some tumor shrinkage or at least tumor stabilization. They found that the patients that got temsirolimus, their tumor was stabilized for twice as long as the group that got the old treatment. And they also found that the group that got the temsirolimus lived longer than the group that got the interferon treatment. And again, these are just averages. There's some patients that'll do much better than these, and there's some patients that won't do as well. There are some side effects associated with temsirolimus, and the side effects include tiredness in about 50% of patients. You can get a rash in about 50% of patients. You can get low blood counts in close to 50% of the patients. You can get nausea and decreased appetite. There can be diarrhea. You can get increased lipids, specifically triglyceride levels. You can have an elevated glucose level that can sometimes lead to diabetes or diabetes symptoms. And you can sometimes get mouth sores. Again, a lot of patients will tolerate this quite well. So based on this information, the 2011 Kidney Cancer Forum Consensus Update, which was published earlier this year, said or suggested that patients should be broken down into their risk group with treatment options as follows. So those that have good or intermediate risk disease, based on those 5 risk factors that we talked about, based on level 1 evidence, randomized controlled trials that have proven benefit, Sunitinib would be an option, Pazopanib would be an option, and Bevacizumab plus interferon. And those patients that have poor risk disease, temsirolimus would be an option, again, based on the information that we talked about. Now, I'm not going to go through the data on some other treatment options because the evidence isn't quite as good. There are select cases, though, where high-dose interleukin-2, which is what our patient this morning had mentioned, can be beneficial. Sorafenib is another option. And in some patients, particularly those that aren't having any symptoms and have a low burden of disease, a period of just watching them is also a potential option. Some patients can do very well for long periods of time like that. And in poor risk group patients, Sunitinib would also be an option. So our patient went on to receive temsirolimus and tolerated it well. Okay, so the fourth scenario is this scenario. This is a 54-year-old male with advanced kidney cancer who is treated with Sunitinib for 3 years. His CT scan now, unfortunately, shows that there's evidence of progressive disease. He has mild cancer-related symptoms. And so the question is, what treatment options would this individual have? That leads to a study that was published in 2008 and updated in 2010. And it looked at Everolimus, which is an oral pill that targets the mTOR pathway, similar to temsirolimus. And they compared it in this randomized controlled trial to a placebo pill. Almost all the patients had received Sunitinib or Sorafenib or both of these agents. And what they found was that the group that got Everolimus did significantly better than the group that got placebo. Although not very many people had a significant tumor shrinkage, many of them did have some tumor shrinkage or tumor stabilization, and that the tumor stabilization rate, if you look as a whole, was more than double that of the patients that didn't get any treatment. The survival between these two arms wasn't different, but all the patients, or patients that were on the placebo arm, once there was evidence that their cancer was growing, could switch over and get the Everolimus treatment. And so that made it very difficult to tell if these patients lived longer from a study standpoint. Another question that comes up often in the clinic is, what about sequential treatment using similar agents? We know that there are multiple treatments that have proven benefit in the first-line setting. We said Sunitinib, Pazopanib, Bevacizumab plus interferon. Many of these work in a similar mechanism or have a similar mechanism of action, targeting the blood vessel pathway. And so the question is there any role for doing sequential treatment with these agents, starting with one, once it stops working, switching to the other? And that leads to a randomized controlled trial that was published in 2011, looking at ExitNib, which is a new blood vessel targeting drug, compared to one of our older ones that we briefly mentioned, Sorafenib, again in a randomized controlled trial. All these patients had been on at least one previous blood vessel targeting agent. Most of them had been on Sunitinib. And what they found was that both agents had some activity causing tumor shrinkage and prolonged tumor stabilization, but that the group that got ExitNib tended to do better, statistically better, than the group that got Sorafenib. ExitNib is currently not available in Canada, but it may become available later this year. That's really all the randomized controlled trials that we have looking at agents up to this point. The question that does come up, I think, is we know that going to a mTOR targeting therapy in the second line, like Everolimus, has benefit, and we know that going to a sequential treatment that targets the blood vessel pathway in the second line has benefit, like ExitNib. Which one of these is better? And the answer to that is that we don't really know yet. There is some what we call retrospective studies, meaning that we go back in time and look in the past to see how patients did and compared how they did. There's potential for biases when you look in a retrospective manner. But in this retrospective review that was just discussed at a major oncology meeting in February, where they looked at patients that went from one targeted blood vessel targeting agent to another, or those that went from a blood vessel targeting agent to an mTOR targeting agent, they found that both groups seemed to do similar in terms of how their outcome. And so both might be realistic or options, but we need more studies to prove which one might be best. So based on all of this information, the 2011 Canadian Kidney Cancer Forum Consensus Update for second-line therapy says that if patients have been on a prior blood vessel targeting agent, that Everolimus would be an option based on randomized controlled trials. And now based on this information from ExitNib, once it becomes available in Canada, that would also be an option. In patients that have been on a prior mTOR targeting treatment, we don't know which the best treatment would be based on randomized controlled trials. Based on less than randomized controlled trials, switching to an agent that has not previously been used makes sense. So with that, I'm going to end. And what I'd like to say is that in the last 5 years, the treatment of kidney cancer has really come a long way. And I think that there are a number of very exciting treatment options that have emerged based on our molecular understanding of how cancer works. But we still have a ways to go. I think the future looks very bright as we think about how we should best sequence these agents, how we should combine them, and with a whole bunch of treatments that are coming down the pipeline, which we're going to hear about next. So with that, I'm going to end, and thank you very much for your time.
Thank you very much, Dr. Gingerich, for giving such a thorough and complete overview of the medical treatments for kidney cancer. Thank you once again.